CEU event. It's the last of the year, but we have some great stuff expected in the future. Today, Richard Lepard is going to present on how medical assistants can help with the geriatric patients. And we talked about his presentation the other day, and it's really good. And I'm sure that all of you have some great feedback and some fun stories to share. I know I have one. We will take a polling question attendance session, maybe about halfway through. Richard, you can just let me know when you're ready to do that, and I'll pop up the polling question. So I'm gonna
help me as well, because sometimes I get kind of, in there.
Yeah. All right, so I'm gonna mute myself. If everyone else can mute, I'll let Richard take it away.
Great, thank you, Dr. Williams. Good morning, everybody. My name is Richard Lepard. I am one of the instructors at Front Range Community College, Boulder County campus. And today I'd like to talk to you about enabling well-being, how medical assistants can help their geriatric patients. Okay, so a couple of requests from the audience members. I know it's a Saturday, okay, it's laundry day, okay, you got family there, I get it, I'm in my slippers, okay, but I have my Zoom top on, so please have your video on when possible, because it really does help me, kind of gauge, people's listening skills, who's there, and this helps me provide a better presentation. So if you can, put on your videos, okay? Also, too, I may call on participants from time to time, this to kind of help me gauge understanding. This is not a test, but to help class engagement, okay? So if I call on you, don't feel like I'm picking on you. However, if you don't know the answer or don't want to speak, throw a lifeline to another participant. Okay, except for Dr. Carey, Catherine, or Carol. All right, so I want to just throw that out there. All right, so just kind of pay attention. I think we're gonna have some fun today, and I look forward to doing this with you folks. Okay, so the geriatric population in Colorado is growing. Kind of the definition of a geriatric person is anyone age 65 or over. Okay, now there are lots of people who are 65 and over who are healthier than 20-year-olds, 30-year-olds, 40-year-olds, but this is just kind of a broad definition, okay, of what a geriatric patient is. All right, and the thing about the geriatric population is that it's growing. Okay, it is growing. The population of those 65 and older in Colorado is expected to double to 1.3 million by 2030. Okay, that's about a 20% increase of the state's total projected population, according to one in five, and that's according to the Strategic Action Planning Group Aging Report. Now, if you don't want to work with geriatric people, you're like, hey man, I'm just going to bail. I'm just going to go to another state, go do my own thing. Okay, you can't run from it. Okay, according to the U.S. Census Bureau, by 2035, okay, the first time in U.S. history, people over the age of 65 will outnumber those under the age of 18. Okay, that's kind of crazy, right? Think about this. All right, by 2035, which is like what, a dozen years from now, the number of people age 65 or older will outnumber the people under the age of 18. It's the first time in U.S. history. Okay, now, how will we care for these older patients? Okay. Currently, the way medicine is practiced today may need to be adjusted due to the drastic increase of the geriatric population. Now, several of you may have read a book called by Atul Gawande. He's a physician, author, geriatrician, and he says that what we've been wrong about what our job is in medicine. We think that, sorry. We think that our job is to ensure health and survival, but really it is larger than that. It is to enable well-being. Okay, we need to enable well-being in our population. It's more than just taking care of the disease. Okay, the disease is, a person is more than just their disease. Okay. So the traditional priorities of the medical system. We do our screenings for colon cancer, breast cancer, cervical cancer, etc. Diabetes control, blood pressure control, maintaining healthy weight, smoking cessation, medication adherence. All important things. We do those every day as medical assistants, okay? These are important, but there are a few more things to consider. There are priorities that matter more, especially to the elderly, frail, or disabled populations. Um, Many of these people want to maximize physical comfort, okay? Physical comfort, receiving treatment at home, having meaningful, oh my goodness, I don't know what's going on here. Having meaningful interactions with family and friends, maintaining as much independence as possible, having a trustworthy care system that is always available. Biggie here, avoiding impoverishment. People don't want to go broke in old age or paying for medical care. Um, Something to consider when medical tests need to be done. They're always concerned of that. Reducing the challenges facing family caregivers. There are so many informal caregivers that care for our elderly, and those informal caregivers are us, okay, between the ages of 40 and 59 or 60 or so. All right. Um, and then also to restoring and maintaining ability to function in daily activities, and of ultimately being in control of one's own life. I know that these are some of the things that as we as non-geriatric people, um, in many ways sometimes take for granted, right? We kind of take for granted these things. But as we age, or as our patients age, I can see this in my parents. Being maintaining that control in your own life becomes even more important. Okay, so as medical assistants, these are some things that we need to remember. Some issues presented today that I talked to you about that affect older patients are osteoarthritis, falls, vitamin D and calcium deficiencies, medications, depression, advanced care planning. Now, throughout this talk, please consider the total impact of the conditions on the patients and their caregivers' lives. Okay, as patients, we are. I don't know if you guys have ever had a medical condition, but as patients, it doesn't only affect us, but it affects our entire immediate family members and even second, third level people. Okay, so throughout this whole thing, consider how it affects the care of the patient and the caregiver's lives. Okay. Osteoarthritis. It's the most common form of arthritis. Older age is the strongest risk factor for osteoarthritis, followed by the female gender. So if you're aging and you're a woman, I'm sorry, but the numbers show that osteoarthritis becomes a serious issue. Okay. Obesity is the strongest modifiable risk. What do we mean by modifiable risk? Does anybody have any ideas what modifiable risk can mean? Something modifiable.
You
Able
can
to
change it.
change.
Yeah, absolutely. Okay, these are something that we're able to change. Okay, um, but for the most part, it's very difficult to change those behaviors. Okay, but it is a modifiable risk. The symptoms: pain, joint stiffness, bony swelling, instability. I want you to think about that word instability. Okay, as we go forward, it affects mostly the knees, hips, hands, thumbs, big toes, neck, and low back. And ultimately, there's a reduction in goodness gracious. There's a reduction of dexterity and potential decrease in quality of life. Now, what types of physical and psychological decreases in quality of life could someone have with osteoarthritis? Can somebody give me an idea?
You can hold things in your hands, it will fall off and
Yeah,
thing.
yeah, yeah, exactly. Yeah, you said that pretty quickly. I mean, it seems like you know a little bit about this, right? You've seen this, right? So,
You mean
not
arthritis?
yeah, yeah. So here's the thing, right? How can this quality of life affect a person's freedoms, right? Their mobilities. You can't feed them. You can't feed yourself, right? Okay.
Right, or
Also,
even if a
to
person who lives in a multi-story home can't go up and down those stairs anymore,
exactly,
or yep.
I had
exactly.
a I had a resident who in a long-term care facility, and she was very discouraged, very depressed half the time. Just the simple tiny little things that she just wanted to be able to do. She was pretty well bedbound without us helping her. And so it took a lot to even put a smile on her face a lot of times.
Absolutely. Absolutely. And these types of things, this dexterity, loss of quality of physicals, there's also psychological components that you touched upon. And a lot of times this osteoarthritis is some of those factors that lead somebody from being independent of being in their own home to heading into, higher level care, okay, which strips them away of their social connections, all right, which can institute a downward spiral to your depression, loss of socialization, those types of things, okay. And also too, this may be one reason why some people don't want to go to the doctors, right? They don't want care, they don't want treatment, right? Because it's like they're going to find something wrong with me, okay. It's kind of like me going to my auto mechanic for an oil change. Like, I don't want to take it to an auto mechanic, we're going to find something wrong, okay. So, these are some of the psychological aspects as medical assistants we need to be ready to address, okay. We need to be ready to address and be able to comfort our patients, okay. I want to kind of hammer this is that medical assistants are more than just people who take vital signs, all right. We're more than people that just take vital signs. We're more than people that just, give a report to the clinician and then call it good, okay. We are on that tip of the spear many times of the care team. We are sometimes the first people and last people that patients see. And so we have to use all of our senses and use all of our judgments to help our patients, okay. So we are more than just people who take vital signs. All right, we got that, right? We know this. We're more than people who chase vital signs. All right, good. There are some treatments, osteoarthritis treatments. The first one I have is exercise. I'll come back to that real quick, okay? Weight loss, if overweight. I've had people who are like, whoa, wait a minute, weight loss? Give me a pill, okay? I don't want to lose weight. I'm gonna have a pill. Give me something, okay? Give me that big needle over there, okay? But weight loss is definitely the biggie there. Walking sticks, cane walker, acupuncture, acetaminophen, topical capsaicin, other creams for treatments, NSAIDs, but those are your ibuprofens, but be careful, there's a risk of gastric bleeding and kidney damage as people get older. Their kidneys don't function as efficiently as younger folks do, so be cognizant of that. Cortisone shots, there's of course a risk of bleeding and infection. And tramadol and opiate pain medications, which also pose their own significant risks of like fall risks and things of that nature, and of course surgery. The reason why I brought these up is because these are things that your clinician may want to talk about, okay? But knowing that there's always risk and return rewards, okay, to these kind of cares. I tend to surround myself with a lot of clinicians who believe in the less is better, okay? Start with the exercise, okay? Start with the exercise. But I want to put in here what they call barriers. Sometimes there are barriers to exercise, all right? Can anybody think of any kind of barriers that people would say, hey, I can't exercise or I don't want to exercise? Can anybody think of any barriers?
They may have had a joint replaced.
Yeah, but they need to get exercise out to, do that, okay? They need strengthening that. You're absolutely right. Okay, some of your barriers, okay? Come on, give me one more.
Weather.
Absolutely weather, okay? You got weather issues. You can also have unsafe or even uneven sidewalks, okay?
Laziness.
Fall risk.
Laziness, yes, absolutely. Fall risk, people who've fallen before, which we'll talk about later, are more afraid to go walk again, okay, because of risk of falls, absolutely, okay?
You might have some elderly that's taking care of grandchildren.
Yeah, time restraints. Yeah, absolutely. Awesome, guys. There's also fear of crime in some places, right? People are afraid of leaving their house. Okay, there's crime. People are afraid of those kinds of things. So if we can get to know our patients, we can get to know our patients, get to talk with them, say, hey, tell me about where you live. What's going on? Do you like to garden? Do you like to do this? Oh, I can't. I live on the third floor by myself in an apartment, and I don't feel like I'm safe. We have these little tiny clues, right, that can affect future patient care, all right? So get to know our patients, talk with our patients, all right? And we're able to provide better care, okay? Okay, great. Thank you so much. Awesome work. Falls. We were, slippery out there today, so I'm kind of like looking out my window to see who might fall, who might not fall, so I gotta go and help shovel today. But falls are a huge risk. And I don't know who brought that. Who said falls? Who was that? Can you tell me your name? Who said falls? Fear of
Jen.
falling.
Yep.
Jen.
Hi.
Jen, thanks so much, Jen. Appreciate that. All right, cool. Okay. Falls. Falls are common. 30% of older adults fall each year. Okay. And the thing about falls is that, you know, you can have your flat on your face fall. You could have your hands out on a foosh, falling out stress hands. But some people, when they think about falling, they may not fall totally, and they may actually say, well, I had a trip, but I didn't fall, or, you know, I'm shuffling my feet. These are just 30% of people who actually diagnosed with falls. These are not people who have had near falls, okay? These are people who have fallen. Falls cause significant injury and expense. Oh yeah, okay. More than 1 in 10 falls results in a fracture or other serious injury. Falls are a major determinant of functional decline and nursing home placement. How can this affect caregivers and family emotionally and physically? What happens to a person before, you know, after their fall? They're trying to take care of them, right? And what kind of decisions go into play of going into a nursing home? Has anybody ever been faced with this? Okay, it's a rhetorical question. You don't have to answer it, all right? But it's a tough decision, okay? Emotionally, all right? The parents and kids and whoever the decision makers are like, man, you know, I don't want her to go to a nursing home. Culturally speaking, okay, we don't want people to go nursing home, all right? Financially, huge, all right? Sometimes nursing homes cost several hundreds of dollars a day, several $100s a day, okay? I mean, there are some nursing homes out there between $50,000 and $100,000 a year, and who has that kind of savings, right? It costs them more to be in a nursing home than they made each year the whole time they were working during their working years, right? Okay, so there we are, all right. But thankfully, falls are largely preventable. Remember that MAs help remove fear, okay, and ensure independence. We're kind of fear removers, right? Are MAs kind of fear removers, right? I mean, I had my blood drawn the other day, right? And one of the MAs in the room, I'm not gonna mention who, but she really helped remove some fear. Okay, I was like, oh my God, you know, I'm a big old baby. Okay, you could put in shots and stuff, but not take out. I'm a big old baby, right? But this MA person, she really helped me remove my fear. She's like, you're doing really good. Just breathe. You're doing fine. Okay. Same with our patients, right? We're here to help remove fear, right? We're fear removers, okay? And also, too, we want to help ensure their independence. All right. You guys are a great group, by the way. I really appreciate the input. You guys are fantastic. Okay. So independence, Susan B. Anthony, longtime woman suffrage movement person. She's also on some coinage, right? Susan B. Anthony dollar. Okay. She said, independence is happiness, and people value independence more than life itself. You guys may have heard this quote or something similar to it, but 80% of older women prefer death to a bad hip fracture that would result in nursing home admission. This is from a 2000 British Medical Journal article. Has anybody ever heard this? Like somebody saying, I'd rather die than go into a nursing home. Has anybody ever heard that? Seen it? Yeah, okay. Yeah, okay. So independence, okay, but it's about independence, okay? Wanting to go where I want to go, when I want to go, okay? But think about the things as you age, right? Osteoarthritis, you can't get up and go like you used to, right? You can't eat, okay? All these things that kind of, you know, play into it. Okay, cool. All right, now, along those lines of independence. So I want to talk to you about falls and how can Van Halen and M&Ms prevent falls. So does anybody's parents ever mention Van Halen to you guys? Anybody ever mention a group called Van Halen? No? Okay.
Come on, Richard.
Not just my parents, but myself.
Really? Okay, great. I appreciate it. Okay. All right. So anyway, and what about M&Ms? Okay, not to be confused with M&M. All right, this guy here. All right. So, but what is Van Halen, or who was Van Halen? Okay.
Amazing.
Who said that? Who said that?
I did, Jenny.
Jenny. Hey, Jenny, thank you so much. I'm gonna scroll down here, Jenny. Let's see here. Are you? All right, great. Okay, cool. Jenny, sweet. Okay, so Van Halen. Okay, what can Van Halen teach us about old care and older patients? So Van Halen was this hair band back in the 80s, and they were really known for their stage theatrics. Okay. They had pyrotechnics, stuff exploding, right? You had David Lee Roth, this guy here. He would swing across the stage on different trapeze attachments and things like that. And it was a big event, right? It was a huge event, okay, especially with the pyrotechnics and things, all right? But one of the things that they required before they actually set up a venue is that they had a contract. And in this contract, in the fine print, okay, in the fine print, they said that they could back out of any venue if inside the band room where they get ready, okay, there was a jar of M&Ms, but inside this jar of M&Ms, there could not be any brown M&Ms. Brown M&Ms were totally banned from the band room, okay? You cannot have any brown M&Ms, okay? That was a guilt. So if they walked in and they found the jar of M&Ms and there was brown ones in there, they bailed. They bailed, right? They bailed. And the reason why, okay, the reason why is because if the venue could not pay attention to small detail, how can they be trusted with the pyrotechnics? Or how could they be trusted with the cabling systems to make sure the bands were safe, right? How could they be sure that if there was a fire, that the people could get out? Okay, so they saw these small little details as a way to ensure that the big important things were not missed. Okay, so I do have an attachment to this article. It's by Andrea Wersoff-Schwartz. She's a medical doctor, Division of Geriatrics and Palliative Care and Veterans Affairs, out of March of 2017. And her title of her article is "What Van Halen Can Teach Us About the Care of Older Patients." And she uses this example of Van Halen and brown M&Ms to help care for older patients. She has 3 things she wants to talk about here. Okay. All right. So the 3 things that she talks about in her article are 1, watch how patients walk; 2, socks on, sock off test; and then 3, look at your patient's toenails. Okay. So I'm going to read to you a little bit here about the first one. She talks about watch how your patients walk. She says, first, when our patients enter the exam room, we can watch how they walk. Gait speed is an important predictor of mortality and is one of the most frequently used criteria to identify frailty. When we notice a patient walking slowly, it can prompt us to focus on their arthritic knees or proximal muscle strength, asking whether they require better pain control, physical therapy, or an assistive device. Their balance, considering whether they would benefit from vitamin D or B12 supplementation, or home safety assessment to install grab bars in their shower, and overall fall risk, prompting an evaluation of medications that could be deprescribed, or fall risk factors that could be mitigated, such as orthostatic hypotension or vision or hearing impairment. So watching how our patients walk, okay? I don't know where you guys are in terms of your clinic situation or whatever, but a lot of times there's a waiting room, right? There's a waiting area, right? So before you actually, engage your patient, okay? You can see how they're sitting, you can see how they're, are they isolated, are they by themselves? But when they get up, all right, when they get up, one of the tests you can see, I don't know, can you guys see me here sitting? One of the tests you can use for people is actually, can they just stand up without using their hands? Okay. So if they have to use their hands or they have to use their neighbor or whatever to help stand up, that could show possibly arthritic knees or decreased muscle strength in the legs. Okay, but a sure sign of good strength and mobility is actually being able to lift yourself up out of your chair. Can you guys do that now? Can you guys stand up without using your arms? Okay, good. Okay, except for Camille. She's all like, I ain't standing up. I called you out, Camille. I called you out.
I'm
All
on
right.
the floor. I can stand up.
Okay, I got you. Okay, no worries. It's all good, Camille. You know I was messing with you. So yeah, so watch your patients, right? And also as you're walking back with them, okay, are they shuffling their feet? Okay, are they shuffling their feet? Are they able to raise their feet enough to clear any obstacles like the carpet? Okay, so use medical assistants. We have to use our senses, right? Sense of hearing, right? Are they shuffling their feet? Okay, could that indicate something else? All right, good. The next one she talks about, Dr. Schwartz talks about, is the socks on, socks off test. And she says, if we notice our patients wearing slip-on shoes year-round or having difficulty donning socks, putting them on, a task that requires balance, vision, dexterity, joint flexibility, and muscle strength, we have a second warning sign that they may be in danger of losing their independence and their ability to dress and care for themselves. A simple sock donner from an occupational therapist, a home health aide, or for a few hours a week, or a referral to a local elder services might be the intervention that helps keep that older adult living independently. Okay, now socks on, socks off. All right, this is an important aspect. People can wake up really early, okay, and shave and put on their tie and their jacket and go to the doctor's office, tie their shoes. But once they get there, okay, then we're able to kind of pull back, like, hey, what is something else going on? Do you mind taking off your socks and shoes? All right. And that shows a lot of mobility, because it is true. I mean, we do take putting on our socks as almost for granted, okay? But try it, on a wet floor in the bathroom with your eyes closed, okay? And kind of put ourselves into the kind of steps of some of the older people, but watching people put their socks and socks on and off. And lastly, looking at your patient's toenails. I know it's not very appetizing, okay? But it's something that she recommends, okay? So she says here that the third of the brown M&Ms, okay, involves paying attention to your patient's toenails. A part of the examination not typically at the top of a busy internist list. A geriatrician named Jürgen Bludow instructed in Atul Gawande's Being Mortal for an older patient, you must always examine the feet. And she says that she's been surprised many times in her career by the disconnect between how a patient is dressed and how their feet may look. Oh yeah, absolutely, okay. She says that even if they don't have any difficulty taking off their socks and shoes, the dexterity required to cut one's own toenails may prove more challenging. She says she asked her students, if you were injured and could not reach your toenails to cut them, what would you do? Ask a friend or a family member, they suggest, see a podiatrist or get a pedicure. When our patients' toenails are long, but they have not been able to do one of these things, we worry about the patient's support network, okay? Caregiver burnout or inability to attend to details, or whether they have the executive function or financial resources to seek the support they need, let alone manage their medications or other instrumental activity of daily living. Simply put, unkept feet prompt a podiatry referral, as well as a closer look at the patient's overall functional status and support system, and perhaps involvement of social work or local elder caregivers. Any thoughts on those three things? Any thoughts?
I like that you give a different option of like going to do a pedicure for patients who don't get a chance to see a podiatrist or don't have like their significant other there to help them because they're just as bad off. So that's nice to
Sure.
kind of see both.
Sure. Thank you. Anything else at all on that? How about the caregiver burnout? Go ahead.
With diabetics, like especially
Yes.
for home health aides and long-term care, like CNAs and nurses aren't even allowed to really touch or cut their toenails. They have to
Right.
go to the doctor. So just the aspect that maybe some of the patients might be a little skittish about, like getting a wound on their foot that's going to cause them to be amputated, might be part of the reason that some patients may not end up cutting out their toenails either.
Absolutely. Yeah, and you bring up, I'm sorry, when you chat, could you just give me your name, please? Because sometimes
Sorry, Kimberly.
Hi, Kimberly, hi. Yeah, and you're absolutely right too. And usually also, it's always good to look at patients' feet, especially if they're diabetic, right? Because they might have a wound that they may not be able to see, and then we're able to see wounds on their feet that may be starting. Another aspect too, whether it be diabetic feet or lesions or whatever, whenever you find something and you need to chart it, try to get a measurement on that wound, okay? Get a measurement on that wound and chart that as in your chart, so you can kind of be able to give that reference to your clinician, because your clinician is going to need that information to see if there's going to be any type of wound care necessary. Yeah, absolutely. Good work, everybody. All right, excellent. How are we doing? I still want to check. Is everybody all right so far? Is everybody okay? Everybody all right? Everybody chill? Yep. Okay, good. All right, sweet. Okay. All right. Okay, good. Okay, sweet. And again, if you guys can turn on some of your videos, it really helped me out a lot if you can. All right, good. So went through Van Halen, went through the 3 things. Well, this thing is touchy today, isn't it? Okay. Okay, other ways of preventing falls. The biggie is always going to be, of course, exercise, right? You got your balance, your strength, and your flexibility. You're going to see in here too throughout this, you're going to talk about what they call intrinsic factors and extrinsic factors. Basically, intrinsic factors are things that go inside the body that can help prevent falls, and on the flip side, it can also cause falls. So anytime anybody's putting anything inside their body, it's intrinsic because you're putting it inside, but it can cause it may cause falls, or it can cause a reaction, positive or negative. Okay, so and then you have the extrinsic, which is something that comes from the outside. All right, so that's kind of want to put this in here. So ways of preventing falls: exercise. There's a Tai Chi video here. Vitamin D. Avoiding any type of harmful medications in the body. Okay, and of course, too much alcohol. Biggie out there is appropriate shoe wear. My mother's a total guilty of this. She's like 73 years old and wears like these chunky kitten heels, right? I'm like, Mom, what's up, right? You know, what are you gonna do, right? It's your mom, right? What are you gonna do, right? Okay. Uh, Vision for sure. All right. And the easy stuff: avoiding clutter, cords, throw rugs, etc. And I don't know if you ever heard this, but I got 2 little puppies here. They're fighting each other. They sound like some raccoons, right? And I got like toys all over the place. And so here I am, saying, don't do as I do, do as I ask. Okay. So avoiding clutter, cords, throw rugs, and of course, common sense: avoiding icy spots, carrying too much, climbing on a ladder, or standing on countertops. I've done all those, right? I've done all those in the last 2 weeks, actually. I've carried too much. I've had stood on countertops. So, okay. All right. So are there any other types of intrinsic and or extrinsic ways people can fall or prevent a fall? Can you guys think of anything else that can go either come inside the body or that's outside in the environment that can precipitate or mitigate a fall?
Hi, this is Jen.
Hey, Jen.
What about using like canes, walking assisted
Yeah,
devices?
yeah,
Mhm.
absolutely. Yeah, that would totally be an extrinsic, right? Yeah, absolutely. But on the same kind of thing, Jen, right? If that crutch isn't fit properly, right? Or if that
Then
cane
it's a
isn't fit
problem.
properly, it could precipitate a fall, right?
Absolutely. Yep.
So we've got these like things where it's like, oh, okay, I got you.
What's better and what's worse, right?
Right.
Exactly.
Yeah, and also to getting used to these assistive devices, right?
Right.
Not using
Well,
them
and
properly.
you mentioned like vision, and that is so huge because how many old people have like macular degeneration,
Yeah.
and so they only see tiny bits and pieces of their
Mm-hmm.
world. And
Mm-hmm.
if they can't see everything around them, but they still try to move, then yeah, that's bad
Yeah.
news.
Fantastic. Yeah, we'll touch a little bit upon this here too. And my kind of the purpose that I wanted to kind of put together is keep people thinking, right? Send you down kind of some rabbit holes and just kind of keep people thinking. This is not the end all be all of what we're trying to do. But yeah, good thought processes. Thank you so much. Awesome. Okay.
Richard,
Yes, ma'am.
I just wanted to share that, building on what you said, pets.
Yes.
I don't recall the percentage, but there was a significant number of falls generated by people's, their most loving companion, their pets, a
Sure.
small dog or cat. So
Sure. You're right. You're right. Because they don't want to step on them, right? So, you don't want to step on a little critter. And the next thing you know, you're like acting like a ballerina on point. And the next thing, you're like head first into the garbage disposal, so, right. So, right. Absolutely. Thank you so much. Okay, good. I love it. Okay. Vitamin D deficiency. Now I know that, as medical assistants, we can't like prescribe or recommend those kinds of things. That's all good, right? But part of what we can do is learn and bring up suggestions to our clinicians. All right. Bring suggestions to our clinicians, because our clinicians are people, right? They're humans, right? They don't have time to like read everything or do everything, right? And of course, we're part of that care team, okay? And I use this kind of phrase of being the tip of the spear. And it's like we are the point people, right? We are the first people to, go into it, right? Good or bad. And our jobs are to care for our patients, for ourselves, and for our clinicians. We got to protect all kinds of different people, okay? But vitamin D deficiency is very common, so common that the current recommendation, okay, for most people is simply don't test, just supplement. That's the way the vitamin D is. And this comes from the United States Preventative Services Task Force, the USPSTF, recommends against routine screening for vitamin D deficiency. Okay, it's an invasive procedure. The American Geriatric Society recommends against routinely monitoring vitamin D levels in participants age over 65, and instead supplement everyone over 65 with at least 1,000 IU daily of vitamin D3. And if you want to check my sources, they're all in the references page at the end, okay? And I run these things through some geriatricians as well. So some things to consider, all right? Vitamin D. Vitamin D supplements versus Colorado sunshine. Vitamin D is safe and effective. Sunshine can cause skin cancer and is less effective as we get older. Okay, why is it less effective? Why is it less effective as we get older? Does anybody remember? Can anybody?
Kidneys.
Kidney, yeah. What else? How does sunshine usually get to us the first phase? How do we feel it?
Going outside.
Yes. Okay. You could have, osteoarthritis, whatever. Yeah. Okay. Our skin. Okay. Our skin becomes less effective to produce, to metabolize the sunshine. Okay. So
I actually heard, so you need to have special amount of sunshine and specific angle or a specific time of the day, and we don't normally do that, right?
Right. Yeah. What little I've read, and this is actually really good, Vita, that this is like a point of interest for anybody, is like go down those rabbit holes, man. Become your clinic specialist on things, right? Become your clinic specialist on these things. But what little I've read is usually needed 15 minutes every other day or every day or so of sunshine to get that type of vitamin D supplementation. So you're right. I don't know the specifics on it, but yeah. Thank you, Vita. All right. What about calcium? Yum. Okay. Recommendation is 900 milligrams of calcium a day. However, too much calcium can be harmful. So people who take a lot of calcium supplementation and things, it could be harmful. Okay. And with increased rates of cardiovascular disease, kidney stones, and even mortality rates. You can check my source on number 4. Food is the best source of calcium, and it doesn't have to be dairy. You can have your leafy greens, your okra. That looks delicious. Your kale. And basically, each added serving of calcium-rich foods adds about 200 to 300 milligrams per serving. So calcium, let's see, super important stuff. Okay, great. Okay, let's go next here. Osteoporosis. Among your older populations, you may see risks of increased osteoporosis, which as female MAs you hear a lot about. The thing about osteoporosis is that you're definitely dealing with low bone mass, and it's what it causes what they call a micro architectural disruption and skeletal fragility. Okay, now if you guys can remember back in like basic medical sciences, like what is it, basic medical sciences 2, okay, we start talking about the skeletal system. Okay, we talk about cells that break down and build up bone, right? Do you guys remember that vaguely? Okay, all right. Does anybody remember what those cells are that break down and build up bone are called? Can anybody tell me? Anybody tell me? Osteoblasts, osteoclasts, right? Osteoblasts build up bone, osteoclasts break down the bone, and so basically it's the body's way of getting it's building the bone, but also getting calcium so it can do its muscle work. Okay, but long and short of that is that this happens, and so over a 10-year period we get a whole new set of skeletal structures, right? All right, so if a person is not getting the right amounts of calcium throughout this 10-year period, right amount of exercise to build up bone over this 10-year period, you start off with a weaker set of bones, right? So it feeds in on itself, okay? It feeds in on itself, all right? So osteoporosis is painless until you break a bone. A lot of times people don't know they have osteoporosis until they break a bone, all right? And remember we talked back in those slides about independence, right? 80% of women are like, look, I'd rather freaking die than go into a nursing home, okay? But the hip is one of the first ones that tend to go. All right, it's one of the first ones that tend to go. So the risk of osteoporosis, advancing age, history of fracture. So if you've had a fracture before, okay, there's increased risk. Low bone density, long-term steroid use. How many of your patients are out there on long-term steroid use? Okay, for different types of steroids. Low body weight below 127. Okay, I got a little ways to go. Okay, but I'm almost there. And then a family of history of hip fracture, cigarette smoking, and excess alcohol use. The research was showing with excess alcohol use is basically, I think it's 2 to 3 drinks a day. Okay, for women. All right, 2 to 3 drinks a day. But I didn't delve deep in this, like, was it this big or was it this big? I really don't know. Okay, so something you want to look at. All right, but osteoporosis is one of those things that is definitely increases with time. What I kind of want to mention with this is that people have heard about osteoporosis for a long time. Okay, this is something that women and primarily women have been talking about for a long time. Okay, but how do you change behavior, right? You can talk all you want about, the risks of a disease, right? You can talk all you want about the risks of disease, but how do you help people change behavior? Behavior change, right? We can talk about the risks all we want, but what happens when you talk about risks all the time, the negative stuff, it scares people, right? It scares people, right? Partially what we have to do with our medical care team, okay, is give people ideas of how to combat these diseases. All right. Hey, what's in my power to help me minimize osteoporosis? All right. So, okay, you smoke. All right, that's cool. All right. And when you're ready to quit smoking, come talk to us. It's out of curiosity, I'm not being judgmental here, but how many cigarettes do you smoke a day? Oh, I smoke 60 cigarettes a day. All right, my patient would say. Okay, cool. Could you cut down to 58? Okay, could you cut down to 58? Yeah, I could do 58. All right. We're not tasking you to do everything all at one time. We can make these incremental steps, right? But if we can give people, if we can help people have or provide them what they call self-efficacy, being able to have a means of control to make some of these small changes, these incremental changes, it's going to become easier. Okay. All right. So as we're talking to people about diseases and disease processes, it scares people. All right. But a lot of times when you scare people, you scare them off. Okay. They shut down. Right. Okay. So as medical assistants, it's kind of our job of being assuring, self-assuring, helping people. Okay, like my MA helped me the other day. Is like, Richard, you're doing great. Just keep breathing. We're almost done. With your blood draw. All right, and those things went a long way. Okay, now if she had said, hey, this is the invasive procedure, right? There's a high risk of infection, right? This student has only done like 4 sticks in her life, right? Okay. You haven't been drinking a lot of water today, right? Okay. I'd be like, I'm done. I'm not doing this thing. Okay. But we have to, build up our patients a little at a time, each visit. All right. To get them going. Cool. All right. Great. Screening for osteoporosis. You have a bone density test, which is usually painless and minimal radiation exposure. It's recommended for all women age 65 and older, and considered in, let's see here, in women younger than 65 and in older men with risk factors. Usually women of small bone mass, Asian American women or Asian ancestry tend to be in the higher risk factors. Okay. Wow. What's going on here?
Richard.
Yes, ma'am.
Excuse me, Carol. I would add to that as risks that women heading into this age who've experienced eating disorders have a very high risk of osteoporosis. And
thank you, Carol. Yeah.
People don't often think about that in a sort of younger person.
I appreciate it. Let me write that down here. I'll put that on my future slide. Thank you, Carol. Appreciate you. Thank you. History of low trauma fractures, and basically a low impact or low trauma fracture basically means a fall from standing height or lower. All right. We're not talking, climbing up on the ladders and things. We're talking just walking and standing and getting a fracture. You typically shouldn't get a fracture falling from that height. Okay. And seriously, this sounds kind of, there are better balance classes out there for people. Okay. For better balance. And, I would encourage, even as, for younger people, teaching children to, do gymnastics, learning how to fall properly. Does that make sense? Like judo, okay? Judo is huge, man. You learn how to fall properly, right? So, teach kids younger. So as they start to age, they know how to fall properly. I think that's part of it, right? So anything you can learn along the way, okay? Certain long-term medicines are exacerbate osteoporosis, like prednisone. Okay, that's one of them. Primary hyperparathyroidism. So anybody's had hyperparathyroidism, increased risk for osteoporosis. History of unhealthy alcohol use, and older adults with increased risk of falls, like with Parkinsonian types, uneasy gait. Thank you, Van Halen, for that. Okay, so pick up on these cues, right? Medical assistants, we listen. That's part of what we do. We listen, okay? So it's like, oh man, I've been on prednisone forever and a day. What? Okay, all right. All these things, right? That kind of come into play. Or, you may have a person who's like, I don't drink anymore. I've been sober for 25 years. Okay, that is a history of unhealthy alcohol use. It could have been AA. All right, we're not being judgmental. We're just trying to help understand some possible future risks. All right, these are all good information that you can relate to your clinician. Okay, the person taking care of them, they'll be like, oh damn, that's a good catch. All right, so as medical assistants, we need to be able to pick up and listen and use all of our senses. Great. Treatments, exercise, especially focus on balance, strength, and flexibility. You got your Tai Chi, you got your yoga, you got some hiking. And there's just something about exercise. It is the fountain of youth. It really, really is the fountain of youth. And it's never too late to exercise. We're not talking about, doing a decathlon and those types of things. We're talking about getting out, walking around the block. Okay. I know people are like, really can't go to, shouldn't be going to the gym right now and doing a lot of low weight bearing exercises. But I know that if you look in your room somewhere, you could probably find your backpack that you had when you're in MA school, right? Load them full of books, put them on and walk around the block with that. Okay. Those weight bearing exercises are going to help strengthen your muscles and your bones. Okay. So those are fantastic. Vitamin D we talked about, adequate calcium in the diet, and sometimes prescription medications are an option. However, if that is the case and you have a patient that needs more medications, be sure to document the patient's meds and any allergies at each visit. Okay, all of them, which we'll talk about in a few minutes. A couple things I'd talk about coming up here is geriatric issues that patients may not want to talk about, okay, but in medical assistants may need to bring up, all right? A couple of them is urinary incontinence and constipation. All right, a couple of them we'll talk about. Urinary incontinence. Urinary incontinence is common, okay? It matters because it greatly reduces the quality of life, but it is not a normal part of aging. Okay, it is not a normal part of aging, and it's usually fixable. All right. I grew up at a time where it was like, well, you know, urinary incontinence was considered common. I grew up, you know, but it's not. Okay, it's something that is not a part of not a normal part, but it is fixable. So urinary incontinence is common and increases with age. Okay, and more common in women than men until about age 80, and then things kind of even out. All right. Now, medical assistants should use their senses to pick up on subjective cues. For example, your patient's stains in the clothing and smells. Okay. Now, I had a patient who he was an older man, and he would come to clinic like, you know, his normal times, whatever, get med refills and things. And he always wore sweatpants, gray sweatpants. And, you know, he's getting up on the scale and he had to step up about, you know, 4 inches or so. And he's a little wobbly. He's like, oh, it's okay. You got you, you know, a little wobbly. And I kind of noticed this kind of smell, like, you know, a urine smell. Right. And I was just like, okay, I just kind of just I didn't want to go there, to be honest with you guys. Right. I really didn't want to go there. Right. And he sits down so I can do his blood pressure and things. And I notice on the front part of his clothing, these little tiny yellowish brown stains on the front where his, you know, in front of his pants. And I was like, wow, you know, these are urine stains. So I go and talk to the doc about it and let him know about it. And sure enough, this guy had urinary incontinence. He was not wanting to bring it up. I wasn't wanting to bring it up, but I kind of felt it was important to bring it up to at least to the clinician, and the clinician had the foresight to talk to him about it. Okay, and they were able to give him some help. But I kind of wanted to share my own kind of I won't call it a bias, but more like it's easy to say things, but when you're actually faced with it, it can be a little difficult, right? To actually follow through. Okay. But as medical assistants, we really need to at least talk to our clinicians about what we see. And these are based on our subjective cues. Okay. All right. What are subjective cues? All right. So the prevalence, geez Louise. The prevalence is over age 65. People living independently, meaning by themselves. So people over 65 years old are living by themselves. This happens in 30% of the women and 15 to 28% of the men. However, in nursing home residents over 65, it's in 50%. 50% of people. Okay. Let's see here. There's some different types of incontinence. Okay, and I quote this directly from Mayo Clinic. It's what they call stress incontinence, urgent incontinence, overflow incontinence, functional incontinence, or mixed incontinence. Your patients are not going to say these words to you. Okay, they're not going to say, I have urgent incontinence, unless they've done some serious research. Okay, but what they may do is say something by definition that might help you understand what type of incontinence it is. So for example, stress incontinence, urine leaks when you exert pressure on your bladder by coughing, sneezing, laughing, exercising, or lifting something heavy. Okay, easy for a patient to say that. I sneeze sometimes and I leak. Okay. Urgent incontinence, a sudden, goodness gracious. Urgent incontinence, they have a sudden intense urge to urinate followed by an involuntary loss of urine, okay? This is, I think that people, they'll get to the door and they put the key in and they can't hold it long enough and they have incontinence. Overflow incontinence, constant dribbling of urine, but the bladder doesn't seem to empty completely. And then functional incontinence. That goes back to you have an impairment from being able to get to the bathroom in time and toilet in time, like we talked about the severe arthritis, and people not being able to unbutton their pants quickly enough, okay? This may be what my patient had because that's why I was always wearing sweats, right? Couldn't unbutton his pants fast enough, all right? So, and there's a mixed incontinence as well, right? So different types of incontinence. And again, these are all not a part of normal aging. They are not a part of normal aging. So urinary incontinence, there are some non-pharmacologic, non-surgical treatment options. The big one is what they call bladder training, okay? It is a bedrock of treatment, and it basically increases the amount of time that you can hold your urine, okay? Basically, it involves urinating every 2 hours without the need to or not, keeping a diary to kind of, keep track of what you've been drinking. Are there any stressors that keep you involved in that? Decreasing caffeine and alcohol in the evenings, and also your Kegel and pelvic exercises. They suggest that as you age, to help prevent this, you want to do between 50 and 100 a day. Again, sometimes patients may not want to talk to doctors about this condition. Why? Why do you think neither the doctors nor the patients are good about bringing up this topic? Why would a patient not want to talk about this?
It's embarrassing.
Yeah, it is embarrassing. Absolutely. What other reasons?
Independence.
Who said that? Who said that?
Elena.
Yeah, Elena, yeah. Independence for sure.
Because then they're gonna say that they might need help and they have to be put in a nursing home. Then they can't live on their own and they have to get more treatment of, well, if you can't use the restroom, then you might not be able to drive soon and you might not be able to do other things that are little tasks that are easy for them.
Absolutely, man. Absolutely. And when you think about it, right? Babies, you're helpless, right? I mean, when you think about like urinary incontinence, you think about a baby, all right? Oh, they can't control their bladder, okay? What adult wants to be thought that way? So they're going to do everything they can, right? People maybe do everything they can to not bring it up, okay? They may also do some things that are dangerous, like for example, not staying well hydrated, okay? Not keep drinking the liquids or fluids. Okay, what does dehydration do to a body? What are some of the risks of dehydration? Skylar, I'm gonna call on you. I like your headphones. What could dehydration do to a body?
You don't pee enough, and then you don't get rid of all the stuff that comes out with the urine.
Right.
Urine becomes darker, and and it's also hard on your kidney.
Exactly.
So you could develop kidney stones.
Absolutely. Skylar, what else?
Skylar wrote in the group chat that her microphone is not working.
Okay, that's fine. You want to throw a lifeline, Skylar?
But she wrote in the group chat, she said, can die of dehydration.
Okay, good. Another thing is when you stand up, you could get dizzy, right? Increases orthostatic hypotension, fall, crack your cranium, okay? So yeah, there are lots of many reasons why a lot of people don't want to talk about it. Also did a search through a Dr. Tarnay from UCLA. It's called Female Bladder Leakage on YouTube, October 2017. He suggests, he's a urologist, he says that 2/3 of women have a lifetime risk of incontinence. It's underdiagnosed and underreported, as we talked about. And this is one of the main reasons of why elderly are transferred to a higher level care facilities. Okay. And also too, one of the things that's scary about it is that it's gradual, it's insidious, so people don't think it's important. All right, so it is important. All right, so use our senses as medical assistants. If we pick up on anything that might seem to suggest it, we need to address it, okay? This doc also talks about the quality of life that's involved with urinary incontinence. Talks about decreased self-esteem in people. He also discusses the fear of being away, the fear of being away from a toilet. There's also a fear of urine odor. So people tend to maybe social isolate themselves more, okay? If people are still working, there's also an absence of work and decreased productivity, which could harm their work lifestyle. Avoidance of sexual contact and intimacy from people, okay? And of course, he talks about too the reduced social interaction with people, and you have to, because they have to always plan around being near a bathroom. The doc also mentions that it's usually 6 years. A person suffers 6 years before bringing the topic up. All right, 6 years of suffering. All right. So that was just some of the kind of little research to kind of think about and kind of chew on a little bit as we work with our patients. Okay, on that.
Richard, this is Kimberly.
Kimberly.
I had a nurse when I was first training to be a CNA.
Yeah.
And one of the things she was adamant about is that, like, of like just rephrasing like things like you would take for granted, like other adults would maybe call them like, I'm wearing a diaper or I'm wearing a bib. But our nurse was like very adamant, is like, do not call them a diaper, because babies wear diapers, adults wear underwear.
Right.
So it's like, she was very adamant about that. And she's like, I
Right.
never want to hear you guys say anything like that.
Right.
And I've had residents that I've taken care of, or clients that I've taken care of, and I was like, well, your disposable underwear, your protective underwear, or your napkin, let's get you a napkin for your neck. And like some of them will kind of look at me like I'm a little bit crazy, but others of them is like, you can almost like see just a dramatic shift, like, oh, I never heard it be called that before.
Right.
I guess it does. I guess it is a napkin.
Right.
Versus a bib. And it just kind of puts the dignity back into their lives. So just like sometimes just simply changing the language of what we call things, I guess.
Kimberly, I love that, man. Thanks so much for piping in there. Like I said about that dignity, right? Rephrasing things in such a way where it's normalizing. I love it. Thank you so much. That's fantastic. Thank you. That's wonderful. Right on. Thank you so much. Yeah. So these are some of the things that we may come across. These are a couple of the issues that may not want to talk about, but we need to kind of address them as medical assistants. And why? Because medical assistants are more than just people who take vital signs, right? We're here to help people remove their fear. We're here to help people maintain independence. Sweet. Constipation is one problem. It affects older adults, 24 to 50%. The risks are older age, female gender. What? I thought estrogen was a protective factor, right? Estrogen was supposed to be protective, right? Physical inactivity is a biggie. Okay, so people who are physically inactive, both male and female, they tend to be constipated. And I think it was, who said that about removing waste from the body? But yeah, it's important because you cannot remove waste from the body. Certain medications increase constipation, like opioids, okay, can increase it, okay? And some acid and antihistamines because they dry you out. So constipation treatments. Now, the thing about this is that it's such a prevalent issue that a lot of times older people do a lot of over-the-counter meds, okay? That really kind of exercise and increase fiber and increase water could kind of mitigate, okay? I know there's a push to not take any more opioids, but if they are taking opioids, the clinician should talk to them about Senna. And I talked to a geriatrician about these types of constipation treatments that are safe for older folks. If not taking opioids with irritable bowel syndrome or chronic constipation, do Miralax, okay? Take daily, not as needed, 1 capful daily times 3 days and double every 3 days. People do not become dependent on Miralax. There are some medications that if you continue to take them, you will become dependent on them. And the irony is that if you don't take the things that you become dependent on, you become more constipated. But Miralax is not one of those medications that will make you dependent, okay? Do not take Docusate, which is Colride or Colace. It is ineffective. It is no better than placebo, okay? So if you see people that come in with who are taking Colride or Colace on their medication list or prescription list, bring that up to your clinician and say, hey, is this something that they should really be on, okay? Or find out why they need to be on it. But here are the biggies here. Adequate fluid intake, 6 to 8 glasses of non-caffeinated, non-alcohol glasses a day. So I've got my water here. Fiber-rich diet and regular exercise. Why is regular exercise important to help counteract constipation or mitigate constipation? What happens in the gut? Anybody?
It keeps things moving.
Yeah. Who said that?
Jenny.
Hey, Jenny. Does anybody remember like the medical term for that? Keeping things moving? Starts with a P.
Peristaltic.
Yes, peristalsis. Yes. Okay. So it initiates that peristalsis. No, this is good. So peristalsis, right? Helps that peristalsis, helps that movement, right? Okay, now, but here's the thing. If somebody is constipated, okay, and they talk about, well, I don't drink enough fluids, could that send us down a different thought process, right? Well, what's the reason for not drinking enough fluids? Are they incontinent? Right? Could there be something going hand in hand with each other? Does that make sense? Right? So, just because somebody says one thing, it's like we may have to dig a little bit deeper in that. All right. Fiber-rich diet. We haven't touched upon it much, but what about food insecurities for older folks, right? Are their hands, are they not able to, shop efficiently because, they have difficulty walking, right? Do they have a social system that is not that's wearing out? Are their caregivers burning out, right? So all these different things that, can play into care. All right. Now let me ask you guys, and it's kind of just a question. But how many of you have patients who have come to you for one condition, but they really need help with another condition?
A lot of time.
A lot of time, right? Same kind of deal, right? Okay. People may come to you have you look at their bunion, but what they really need help is with their high blood pressure. Okay. All right. Same kind of deal. All right. Same kind of deal. All right. Okay, good. Questions or concerns at all? You doing okay? Doc, we're at 1 hour, 9 minutes. Is it time for a break or a quiz or something? You okay?
Yeah, we could take a break. I think I think the polling questions, I think, Richard, I made those polling questions based on our timing the other day. So
okay.
You haven't quite covered the information from the poll, but why don't we take a break and get some tea or coffee? Maybe 5-ish minutes.
Sounds
come
good.
back at, how about we come back at 10:15, 10:20?
Okay, sounds good.
Okay.
Okay, thank you.
Okay. So I have a friend whose mom had back surgery. She had a really old back surgery that involved a cage around her vertebra. And years later, the cage kind of fell and kind of crumpled. Anyway, it was putting a lot of pressure on some nerves, and so she had to have that taken out and all of that stuff cleaned up and fixed. And anyway, so she's recovering from this back surgery, and she's supposed to be doing some rehab and all of these things. And my friend this is in Arizona, and my friend lives in Seattle, and so she was there for a time, and then she went home, and she was probably gone for 2 months, and then she went back to visit her mom and see how she was doing, and it wasn't good. So she wasn't able to do the rehab, and she was very spacey and confused and a little bit combative. And anyway, her personality had changed. And this is at Thanksgiving. So at that Thanksgiving dinner, her mom totally passes out at the table in the middle of talking, and then wakes back up, after Tracy's like, oh my God, what's going on? And just continues with the conversation that she was having, and very, very confused. So she calls the emergency services, and an ambulance comes to get her, and they go to the ER. And it turns out that she has a really, really bad systemic urinary tract infection. And she doesn't have any symptoms, though. Like, we think of urgency, frequency, burning, and pain when you go to the bathroom, and these weren't her symptoms. And it is documented that it does present differently in older people. So the doctor comes in, and he's talking to her 80-year-old mom about urinary tract infections and about sex, and asking her if she's sexually active, which she is. She has a boyfriend, but she says, we don't engage in sex that involves penetration. We only have oral sex. And the doctor's explaining, okay, that disrupts, the bacteria in the mouth can disrupt the bacteria in the vagina and the urinary tract, especially for women. And she's like, but I'm really careful. I'm really clean. I douche before and after we have sex. And the doctor's like, what? Douching is even worse, because it just wipes everything out. So that can contribute to this bacteria growing. And she's like, it's impossible. It is impossible, because I mix Listerine with my douche. And Tracy's like mind blown, just actually for the fact that her mom is still having sex, but that she douches with Listerine, which I can't even stand. I mean, it's hard to have in my mouth. I can't imagine it anywhere else, especially there. But she mixes the Listerine with the douche for the benefit of her boyfriend, so it's minty fresh down there.
Wow, that is thoughtful of her, though.
So thoughtful. She's a really, really thoughtful lover.
Oh my God, that sounds fantastic. You know what? That is amazing. Wow.
We all have different expectations now.
I'll never look at a ball of Listerine the same way.
Oh my God, Carrie, I've been laughing about that for days.
Oh my gosh. I have a lot of memes and clip art now that combine.
Send it.
Okay.
Well, I want to tell you, you guys are just absolutely fantastic. I was a little nervous this morning, because like, oh my gosh, I hope people feel like they can talk. I won't scare them away. But thank you guys for all participating. This makes it much more enjoyable for everyone. So thank you for sharing the stories and the discussions. So
yeah, especially with these stories, Carrie, that's amazing. Learn what geriatric patients could do, right?
Sure. And yeah, it brings up a lot of good things, right? I mean, what we hear, we're not trying to be judgmental, right? We're just trying to, just figure out what's going on so we can help. And then I think Dr. William brings up a good point too, in terms of health literacy, right? People, grab onto things that sound good to them, right? Or might work, and then they go for it, right? So there, you have health literacy issues. You have, so many different things. So that's fantastic. Well, cool. So we talked about constipation. We're going to move away from that. We're going to talk about insomnia in older folks. And I read an article not too long ago, and this doctor was suggesting that will sleep become a sixth vital sign? How many of you have battled insomnia in the past?
Oh,
Okay,
daily.
yeah. Okay. So the thing is that insomnia, okay, lack of sleep, if you go for long periods of time, it will change you. It will change you as a person. I mean, I haven't had a chance to look at the, in-depth studies, but I remember reading some articles that, like, if you went, I think 2 weeks or so without sleep, I mean, it could be pretty harmful, even mortality, the risk of mortality. So a lot of older people battle insomnia. And there may be some incidents of, decreased melatonin in the body, that happens as we age, etc. But the prevalence of insomnia and interrupted sleeping patterns increases with age. In one study of older people, only 12% reported normal sleeping habits, only 12%. Late life insomnia is often persistent and may prompt self-medication with over-the-counter sleep aids or alcohol or both, right? So one of the things I want to kind of bring out, and we'll talk about it later, but just because something's over the counter or just because something's herbal doesn't mean it's not a medication, right? Okay. And a lot of times people who are older, they will self-medicate with over-the-counter sleep aids or alcohol or both, okay. Medications are not ideal for the treatment of chronic insomnia later in life or earlier in life. There's what they call sedative hypnotics. You guys may know them more in the street terms as Ambien, lorazepam, Lunesta. Okay, has anybody ever heard of these? Ambien, lorazepam, Lunesta? Yeah. Well, so there was a study, and I'll explain these numbers here. But there's what they call number needed to treat, number needed to harm. And the study showed that for every 13 prescriptions given for one of these drugs, one patient may get only an extra 20 minutes of sleep for 13 prescriptions. But out of those 13, 2 people may experience a harm like a fall or a car crash or something detrimental. Okay, so the number, the harms outweigh the potential good. But why do people still take these drugs? Because they want to sleep, right? And the marketing's good, right? The marketing's good, okay? So these are some very dangerous sleep aids. And also too, got to remember that anytime you have a sedative hypnotic, okay, it basically relaxes the whole muscle relaxant, basically. So you increase risk of falls, or increase risk of deliriums, you increase risk of accidents, increase risk of all kinds of things, increase risk of risky sexual behavior, right? Whether that involves Listerine or whatever, okay? So with this type of insomnia, there's some ways we can help improve this, okay? The biggie out there is cognitive behavioral therapy for insomnia. It's more effective than medications, has no side effects, and it maintains benefits long after stopping the treatment. There's some free ones out there. It's called CBTI. It's a free app. It's a download that you can download on the computer. Okay, it's basically a relaxation app. Also, too, your light yogas. Okay, which are very low in physicality, but they do stretching exercises, kind of burn off some of the anxiety or stressors. And also your meditations that are out there. I don't know if anybody ever tried it, but meditation's fantastic. Okay, it's kind of like 1 or 2, 3 minutes a day. And then also to consider melatonin, 3 milligrams to 6 milligrams each at bedtime, and be sure to ask your doc if that's appropriate. Okay, but melatonin is something that helps with people sleep. It is also used off-label to prevent delirium in people. Okay, so some of the things there. My geriatrician basically says to tell our patients to avoid anything that has the word PM in it. Okay, anything that has the word PM in it, you want to avoid because it has diphenhydramine. That is another medication that will zonk people out and increase your risk of falls. Okay.
Richard, I have this from Charlotte's Web. It's a hemp company, and
Yeah.
it's specifically geared towards sleep. It's
Nice.
10 milligrams of plant-based cannabidiols, cannabinoids,
Sure.
and melatonin.
Sure.
So it's 2 gummies a night, and it's
Legit.
It's been my bedtime buddy for several months.
Yeah, I mean, if something, if you can't sleep, you just hurt. You just hurt, right? Insomnia. I mean, lack of sleep increases it decreases your pain tolerance, decreases your tolerance for everybody. Right? So, sleep is one of those terrible things. Okay. So, yeah, for sure. Thanks for that, Doc. You may have to send me the link on that. Try those out. Okay.
Richard, I would add that our sleep life is just as important as our waking life.
Yeah, absolutely. And Carol, I want to kind of piggyback on these things here too, is that our circadian rhythms, right? Our sleep patterns, okay? They change, but also to our environment, right? Our environment can dictate our sleeping patterns, okay? The cell phone activity, the blue lights, the screen time, okay? There are so many studies that are coming out now that if you look at a screen, it takes, I don't know, an hour and a half of your body to shut down or something of that nature, right? I mean, I got to look at the times, but it's a screen time, right? It's light that goes into our bodies. And it's somewhat of a natural function, okay? Kind of an art, I kind of like art. And prior to the electrical lights, okay, we had what they call first sleep and second sleep. We went to bed when it got dark, right? We woke up when the sun came up, okay? But light, okay, has changed our circadian rhythms, okay? So our environments can change those rhythms. If you have an older person that lives alone, or or maybe even you have an older person that is required to live in a household that has people working different hours, those lights and things like that can interfere with their circadian rhythm. Okay, so interesting stuff out there with sleep. All right, but when you have a person that comes to us, maybe we should ask them, hey, how are you sleeping? Okay, how are you sleeping? Oh, I'm sleeping fine, I sleep terribly, or I haven't slept very well. It can play a lot into their perhaps their inability to become forgetful, not take their medications adherently. Okay, all these different things that could happen with lack of sleep.
I have a fun little tidbit about sleep.
Go ahead, Jen. Yeah, please.
I'm a type 1 diabetic, and so I have noticed just throughout life, like having small kids and having to wake up, during the night, if I don't get a solid 8 hours of sleep, my blood sugars for the next 24 are erratic, which is crazy because you wouldn't think sleep would have anything to do with that, but it most definitely does. So if I don't have a good night's sleep, my blood sugar always runs higher. So it's just crazy to see what it does.
Yeah, absolutely.
Richard, I follow the S rule, or the bedroom is for 2 things: sleeping and sex, and no screens. So if you think about the S's.
I like it. I don't know how much play that would get in my house, but I like it. That's awesome. Well, good. So one of the topics we want to talk about is frailty. Okay, frailty elevates the risk of aging. All right. And when we deal with frailty, all right, the definition, you guys have seen it. You see it, when you see it. It's decreased functional reserve that results in increased vulnerability to stressors. basically as people age, they have very little left in reserves, very little left in the gas tank. All right. And as they've been aging and they start battling, the osteoporosis, lack of sleep, a fall here or there, they become increasingly frail. Okay. Basically, frailty is as a metaphor, is that if you are, having to go up a mountain and you only have, half a gallon in your gas tank, right? I don't know if you're going to make it. There's no other reserves. That's it. Okay. So, but frailty is definitely there, and you'll see it. The result is increased risk of functional decline and death. Our job as medical assistants is to mitigate frailty, try to our best to stop people from becoming frail. Okay. That's my raccoons back there. Come on, girls. Okay. Basically 7% of community dwelling adults are frail, and 30% by the age of 90 are going to be frail. All right. But exercise is a way to kind of help battle that. Sorry. So this is Lucy. She's 14. She's like 80, and she's my geriatric pup. So, all right. So diagnosing frailty. There's what they call a frailty wheel. There's four simple questions. So when you have a patient that comes to you, what is their age? Okay, as they start reaching 80, frailty is definitely an issue. Any assistance with medications? Do they have any issues taking them? Can they hold them, right? Can they actually hold them? Can they remember what to take, why they're taking them? Assistance with bathing, huge. That self-care, once that starts to happen, that's definitely a sign of frailty. And do any health conditions interfere with function? Remember, our falls, our urinary incontinence, all those go into the theme of frailty. Keep diagnosing. Why does frailty matter? Okay, there was a study, and basically frailty predicts any type of future surgical risk or future risk to care. If somebody's frail, they're going to have lots of post-op complications. It's going to increase their length of stay. And once somebody is really frail and they get to a skilled nursing facility or assisted living facility after surgery, chances are pretty good they're not going to make it out. Okay, so if we can help stop that wheel of frailty from starting, it's going to have a better outcome emotionally, physically, socially for our patients. Interventions, exercise. I talked to multiple geriatricians. Is the only intervention that's been shown to have a positive impact, even the frailest older adults. That means getting people to walk. Also, exercise too. It gives a social component to people, right? You have to have that sociability, right? Helps people be social. But exercise is the only known intervention to help. So if people are like, hey, you know what? I don't want to get out and exercise. All I want to do is sit in my sofa and compost while I binge on Netflix. It's like, no, you got to get up. We got to go. Okay, let's go do something. I don't care what it is. Okay, we have to get people moving. Appropriate screenings for frail elderly, functional status and home safety. We'll talk about medication review in a few minutes. We'll talk about vision in a few minutes, hearing. We touched upon malnutrition and food insecurity. Okay, people don't eat. They don't want to eat, okay, for whatever reason. Falls and balance. We talked about the bone density test. We'll talk about depression, and we'll also touch a little bit on the cognitive issues. Vision. Yeah, I don't know who said it, but low vision is associated with decline in health, functional status, quality of life, cognition, increased risk of falls, depression. Absolutely, okay. If you notice in your patient that they may not be remembering things efficiently, they may have trouble filling out their forms and the medical office, okay? They may be shuffling their feet. You need to schedule them up for a vision check, okay? I know that we can do the Snelling eye chart. We could probably do Ishihara, okay? But people really need to go to the ophthalmologist to get screening, especially for your patients that may have other comorbidities like your diabetes and things like that, okay, for retinopathy. Also, too, if patients have multifocal lenses, be careful that they don't use them on the stairs or when hiking, because those shifts and perception can really precipitate a pretty bad fall. All right, so these are things that kind of happen. Hearing, age-related hearing loss affects 40 to 50% of adults by age 65. 40 to 50%. Okay, this is one of the things that kind of a personal thing, because my mom, I mean, she is straight up deaf, right? But she is so vain, she will not wear her hearing aids. And she won't wear her glasses either. She's just too dang vain, right? And I'm like, I try to battle this all the time. But one of the things I'm noticing about her is that since she's had this hearing loss, is that she is becoming more socially isolated. She thinks that people are talking about her, right? They probably are, okay? But I'm just saying, when you want to hear it, I mean, yeah, mom, they're talking about, but when you want to hear it, okay? Poor self-esteem, cognitive decline, and functional disabilities, okay? So here's the thing. We are all people that have to take information in, all right? We're not closed environments. We take information in and we put it out, okay? Now, granted, we all have our own news feeds, okay? And we all hear our own thing, okay? But that's by choice. But whenever someone has a decrease in hearing, think about what we use our hearing for, right? To interact with society, okay? And you can definitely see how people can become depressed, socially isolated, lack of poor self-esteem. Why is nobody talking to me anymore? Well, they're talking to you. You just don't hear them, or they're tired of yelling, saying, "Hey, I'm tired of repeating myself," right? So they just disengage from you. Okay. Currently, there is no recommendation for routine hearing screening for asymptomatic people 50 or older. However, the guidelines are under review for that. But if a geriatrician's advice is that if you or a loved one notice any hearing problems, get it checked out, okay? And she says don't use Q-tips, all right? But yeah, the huge issue is hearing, okay? How many of you had to do impacted cerumen removals in the clinics? You guys have to do those? Yeah, right? It could be something as simply as that to help somebody with their hearing, all right? Or it could be something more. But yeah, hearing is a huge, huge thing we need to be looking out for our patients. You may notice it too when you may be bent over, looking at the blood pressure, and the person, you say something to the patient, but they can't read your lips, so they don't say anything, right? So these little tiny cues, that we pick up on as medical assistants, we can relate to our clinicians, okay? To help our patients. Right.
Richard, I'll add, because you know how versed I am now on Medicare, that Part A and B hearing aids are not covered.
That's right.
They may be covered under Advantage plan or have, some discount, but right. That certainly is a barrier I've experienced in my own family.
Carol, you're absolutely right. Thank you for bringing that up. So we look at barriers, right? We talked about exercise barriers. What are barriers to hearing, right? Hearing aids. Those things are not cheap. They're like $4,000 to $10,000, right? $4,000 to $10,000, right? For a pair of hearing aids. That's a lot of money, right? And a lot of times people like, I don't want to spend that money because A, I don't have it, or I want to leave it to my kids, or save it for independence, right? Money's independence. To buy you independence, right? So there's some definite issues there for sure. Thank you, Carol. Appreciate you. Thank you.
Richard, I was just going to add, I think that all the mask and shield wearing that we're doing in the office has contributed to kind of being able to tell when someone's having a hard time because they can't rely on the lip reading, like you said.
Camille, thank you for that. You're absolutely right. And the thing is too, is that if we have people who may be hard of hearing or lip read, there are those clear masks. They're kind of hard, harder to find, but trying to have a few of those clear masks on hand that would facilitate lip reading. Okay, but you're right, Camille, absolutely. Okay, but so maybe in this way, this kind of COVID thing is kind of a blessing and a curse, that we're able to find these people that we may be able to help out that we may not have had we not been wearing masks, right? So if you can save 1, 2, 3 people.
Sorry, this is Kimberly again.
Hi,
The
Kimberly,
other
yeah.
thing, like some of it might be just their age, but if they have other underlying disabilities like auditory processing,
Right.
the lack of face-to-face contact also impacts people understanding. So it may not be that there's a hearing problem. It may be just that there's a general understanding problem. And
Totally.
as people advance in their ages, they're going to have the additional cognitive
Totally.
problems on top of that too.
Totally. Totally. Yeah. Thank you for thinking outside of the box, right? You know, so we're thinking outside of just, you know, our topic, which is awesome. Thank you for that. Thank you. Along the same lines, when you're talking about older people, we think about medications. And this is a quote by Voltaire. Okay, Voltaire. He says that physicians pour drugs of which they know little to cure diseases of which they know less into humans of which they know nothing.
Nice.
So Voltaire, though, he was a French writer born in 1694 and died in 1778. So, you know, we are still talking about these topics, you know, from 17th, 18th century, you know, philosophers and writers, right? Still among us. So again, as medical assistants, we need to talk to our patients, right? Get to know our patients, okay? Get to know our patients. We need to trust them, they need to trust us, right? Because we're only as good as information they give us, right? And then the treatment that they get is usually only as good as information they give to the clinician or we help give to the clinician, right? So these things we have to do. Okay, but that's Voltaire. Now it's been a long morning, so we're chatting about pills and beer. Okay. So how can beer help geriatric patients have a better quality of life? People are like, okay, I see people jumping on video now. I don't know what that's about, but I see it. Okay. So how can beer help geriatric patients have a better quality of life? Okay. Not liquid beer, but this thing called the Beers List. Sorry, guys. Okay. So it's named after Mark H. Beers, and he's a medical doctor. Okay. And he comes up with this thing called the Beers List. And the Beers List is a list compiled of medications by the American Geriatric Society outlining drugs that may be inappropriate for elderly patients. Okay. I want to remind you that you may need to remind your clinicians about the Beers List. This is just a fact. Okay. This is something that a lot of clinicians may have heard of one time, but they need reminding about this. There are lists of medications that are used throughout medical care that the patient may have retained and still taking that were fine when they were younger, but as you age, they can become quite dangerous. Okay. This is not in the slides, but usually the medications when medical drug companies are doing medical trials on medications, a lot of times their medications are based on 155 or 165 pound male aged 22 to 35 for dosages. Okay. That is very different than what you'll see in your geriatric population. Okay. And I think Carol brought it up. I think Dr. Williams brought it up. I think several people brought it up. But as you age, your body changes and your body handles things differently. Sometimes things present differently than they would as a younger person. The Beers List is one of these things, these tools that you can save people's lives with this. Okay, I've done it once before with the Beers List, but you can save people's lives. Before we get into a little bit, I want to let you know that this is the Beers List is not a hard stop on any of the drugs. It's kind of a flashing yellow light, not a red light. So anytime you see it, you need to tell your clinician about it to make sure this is still appropriate. Okay. So one of the things is the Beers List helps address is what they call polypharmacy. Okay. Poly means many, pharmacy is drugs, so many drugs. Okay. Usually it's more than two, but a lot of times your older folks are taking 3, 4, 5, 6 pills, right? A day. Do you know anybody who takes more than 6 pills a day? Oh yeah, right. That's what I mean, right? So, but anytime you start taking more than like 3 pills, there's going to be an interaction. okay? And you multiply that as people age. That's how it is. So approximately 75% of outpatient visits results in a drug therapy and or prescription being written. What this means is that for every doctor's office visit, okay, for 3 out of 4 of them, somebody will walk out with a new prescription or the prescription will be renewed. 3 out of 4. 95% of adverse drug reactions are considered predictable events. Okay, what they mean by that is if they went through and they looked at all the different drugs and you see all the potential side effects and interactions, you see that this could happen. Okay, this is multiplied exponentially by the number of medications people take. Also, too, for every $1 spent on prescription drugs, over $1 is spent in medical costs due to adverse drug reactions.
That's crazy.
Yeah.
Oh my gosh.
Yeah. Okay. True stuff. The problem with polypharmacy continued. Older adults are more likely to be on more medications by taking both prescription and over-the-counter medications. True or false?
True.
True. Very true. Okay. Older adults are at greater risk of suffering from adverse drug reactions. Yeah.
True.
True.
And out-of-pocket expenses for medications may be significant. Okay, so sometimes people, even if they have Medicare or whatever, okay, it's still significant expense. So sometimes people may, you've heard of overdoses. What about underdoses, right? People cut their medications in thirds, right? They're not taking their right dose, right? They may be spending more money on over-the-counter stuff thinking that this is just as good. Okay? There's a lot of things going on there. How do we tackle it? Okay. This is where your medical assistants and docs can save some lives. Okay. It takes a little bit more time, but it's worth it because this way it won't be on your conscience. Brown bag medication review. You get your patient to bring in the prescriptions, all over the counter medications, all herbals, everything they ever had. You bring a brown bag in. Okay. A lot of times they have EHR, EMR, where you're able to type in their medications. Okay. And you're able to run an interaction list, okay, for any interactions. Also, too, you can run this against the beers list. Okay. I had a patient that came in. This is like, I don't know, gosh, it's like early in the morning before the docs came. And I just listened to a talk about the beers list like 2 days before. And this guy comes in, and I'm serious. He is just like, all over. He is totally looped out. I mean, his wife's like, I don't know what to do. He's been acting like this for like 12 hours. I was like, look, there are no doctors here. You need to go to the emergency room. Let me call you an ambulance, right? She goes, no, I don't want an ambulance. I was like, look, he needs to go to the ER. He is delirious. He doesn't know where he is. I was like asking him questions like, he's like, existing patients asking me, do you know where you are? Do you know what time it is? He was like, okay. I was like, wow. So I printed out his medical record, his allergies, his drug list, and I looked down on his drug list, and sure enough, man, there were 2 drugs on this beers list, right? And I highlighted them real quick, and I made a note. I was like, dear ER doc, these drugs on their beers list, please look and see if these are causing interactions. The patient may have delirium, right? And so she takes this list, she goes to the ER, and 3 days later she comes back and the dude is fine, right? And sure enough, these drugs were on this beers list. It was the coolest thing ever. I thought I was like, listening, I had my camera off and I was like, I don't know, and I was like, damn, I'm glad I listened to that thing, straight up saved this dude's life, right? It was so freaking cool, right? And, granted, we're not, as medical assistants, we can't say this is that, right? We can't, but we can learn about things and we can highlight things and say, take this, go, right? And we can, we're more than people who take vital signs, right? So it was super freaking cool. All right. So anyway, review these medications. Okay. Also, too, this might be a time to elicit patient and family preferences as to overall care goals. It's like, what's important to you? Why are you taking these medications? Okay. They're like, I don't know. They just told me to take them, right? Okay. But you might want to ask them again, like, What's important to you? What is part of your care goals? Why are you taking these medications? Okay. And remember to bring up non-pharmacologic patient therapies with your care team members. Okay. What I mean by that is physical therapy instead of NSAIDs for low back pain. Okay. And we talked about non-steroidal anti-inflammatories as damaging the kidneys or increasing gastric bleeding, right? Is there a way to maybe do physical therapy? Bladder training for incontinence, okay, instead of getting medications for incontinence. Cognitive behavioral therapy for insomnia, nasal washes for allergies instead of taking the Benadryls that knock you out, okay, and exercise for nearly for everything. Now, as medical assistants, we need to be cognizant of this thing called clinical inertia, okay? We're there for our docs, we're there for our patients, okay? Again, review the medications at each visit and in depth at least once a year. How many, now I want to ask you guys this, okay? And I mean, I haven't talked to any of you guys in a long time, but I know you guys are working in the field. How many of you have patients that come in with like a list of medications and are like, I don't know why I'm taking that medication, or, oh, I've been on the medication for 15 years.
A lot.
Yeah. How many of you know why you're still taking this medication? I don't know. They just keep redoing it, right? They just keep giving this again. I'm willing to bet 75% of you, if not more, have patients like that, right? But why? Okay, why? Okay. Think about the reason for why each medication is being used. Is it still needed? Okay. Think about we talked about I won't call it the harm, but the pressures on the kidneys, the pressures on the liver, right, of metabolizing these drugs, right? Is the medication still needed? That's not for us to say. That's for our doctors to say, right? Okay. Do harms outweigh benefits given current health status or patient goals? Okay. Remember that MAs try to make things easier and safer for the clinicians and patients, right? We want to help minimize this thing, all right? So along those ideas of simplicity is often a matter of focus, which we do quite a bit of. Now I like to shift gears from the body to the mind to discuss depression among some of the geriatric population. Depression later in life, it's not uncommon. 2 to 10% of community dwelling over 65 have it. I thought it was going to be higher than that. The risk factors, again, are being a woman, social isolation, widowed, or divorced. Can anybody remind me what are some things that could cause social isolation? Margaret Sutherland. Margaret, are you there, Margaret?
I'm here.
Hey, Margaret, how's it going?
Good.
Hey, yeah, I'm doing well. Hey,
what's that?
Good to chat with you again. Could you help me out by reminding me what may cause social isolation in people?
Hearing problems.
Yeah, definitely. Thanks, Margaret. Appreciate you.
You're welcome.
For sure. You got social isolation, right? And there's also increased prevalence of depression with comorbid medical illnesses. And comorbid just basically means more than one medical illness, right? And as we age, chances are probably pretty good. We may have 1, 2, 3, or 4. Who knows? Okay, but the more medical illnesses you have, the more likely to have depression. As medical assistants, you may have to kind of gauge this, and that's through anxiety and depression, which you may already have used, but the PHQ-9 and the GAD-7, okay? The PHQ-9 basically is for anxiety, and the GAD-7, the PHQ-9 is for depression, the GAD-7 is for anxiety, okay? These are just like a list of questionnaires for people. Sometimes anxiety and depression go hand in hand. Sometimes anxiety and depression, people may not be able to differentiate between the two, but there's still things that can affect the psyche. I tend to like kind of think of as kind of a way to remember it is that depression tends to be more past oriented, while anxiety tends to be more future oriented, right? You tend to worry about things that happened in the past. It tends to be more of a depression kind of thing. Are you really anxious about things that are worried about the future? That tends to be more anxiety oriented, okay? but both your GAD-7 and your PHQ-9s, as medical assistants, you probably will be administering them. They both need to be charted in your EHR, EMR, and they're both billable, okay? So you can bill those codes, okay? So anytime you have comorbid medical illnesses, we can have depression. People have a stroke, 47%, heart attack, 45%, Parkinson's, 39%, 33% increase of depression. Depression later life, what it looks like. Sadness, feeling blue, may be less reliable as an indicator in frail old patients and in the very old. Changes in mood and interest, and again, social isolation. And we talked about how do people become socially isolated. And so going back to the beginning of the day, you got your list of patients, you're seeing people kind of come into the clinic, they're sitting there, and you're looking around the corner and you're seeing people, and how can you pick out somebody who might be depressed or have anxiety? Especially if you see an older person who's just like this, sitting there like this, not engaging with their surroundings, right? Nobody's there to help them, okay? That might be an indicator, right? Okay. So, is the person depressed? Are they socially isolated? Can they hear us? Can they see us? Is it depression? No, or is it just a lack of hearing? We don't know, okay? So all those things that we see, okay, that we can build a picture as to perhaps what's going on, all right? Everything's like a little clue, like a little crumb that we need to pick up to figure out what's going on with our patients. Okay. Again, depression later life, it's associated with increased risk of functional decline and death, all right? Yeah. Overwhelming majority present in primary care, often with physical symptoms. You'll see this primarily with people who come in, they're just not feeling well. People even, it is what it is. America is one of these places that mental illness is still considered a taboo topic in many ways, right? People don't want to talk about mental illness. But they can talk about a stomach ache. They can talk about, just not feeling well in my gut, okay, or whatever, right? So sometimes people may somaticize, okay, but the reality is maybe depression or anxiety. Startling statistic, white men over the age of 65 have the highest rate of completed suicides. They are also, this first episode of suicide can be seen the first rate of depression. They try to see a doc within the last month, but for some reason it wasn't addressed. So if people kind of make these kinds of maybe subtle cues to you, just pay attention, because for the suicide issues. Treatments, again, exercise, I put that on number 3 because I always put it up top. Okay. Okay. Anytime you exercise, you'll have your endorphins released. That could help. And antidepressants, they're just as effective in older adults as they are in younger adults, with exception of dementia. If somebody has dementia, the antidepressants don't seem to work as well. And there's also counseling. But again, we come back to barriers, right? You come back to barriers. Some people don't want to go to counseling. People, especially in the older generations, think, head shrinks and counseling, that's for wussies, right? That's for people who are weak, right? They don't want to do that. So these are some of the things that I think that, I think Kimberly in a tangent made reference to, is like you normalize it, right? You don't make things sound bad. You try to help them along these ways to help them feel better. There are some people out there who have been depressed for so long, they don't know what it's like to feel good again. Right? Okay. So we have to address it. We have to, hit people between the eyes sometimes. We have to ask them, do you feel suicidal? Okay. And you'd be surprised the answers you get. If they feel suicidal, that's something you definitely need to talk to a clinician about. And especially if they have a plan. Do you have a plan? You made a plan. Those are some serious questions. But you know what? I've had a couple of cases where I've asked people if they were suicidal and that helped them. I've had a couple of cases before I was a medical assistant where I didn't ask a person who was suicidal and they killed themselves. So I carry that on me. So if something inside you says, hey, should I ask this question? As long as you are polite about it and you don't exceed your scope, okay, you should ask them. That's my opinion. Okay. By the time you're 80 years old, you've learned everything. You only have to remember it. George Burns. Okay. For you who remember George Burns, is this kind of funny guy. All right. I kind of feel this way when I was in MA school, the exam. It's like, hey, I have no problem learning it, just remembering it. Right? Has anybody ever had that situation? Okay. All right. So memory loss. A lot out there, memory loss, diagnosis. And so the people, as you age, it's not really memory loss. Sometimes you do take a little more time retrieving the memory, retrieving it. Okay, you're a little bit slower. Okay. But it's not that you've lost the memories, it's that you're a little bit slower on the uptake on retrieval. Older folks, man, they got a lot to give, man. They got so much history. They got so much talent to give, and they still give a lot. They volunteer in the community. They have a lot to share for us younger folks. Parenting skills, okay, don't worry skills. Everything's gonna be okay skills, you know? And I think as medical assistants, we can really kind of step up and be an older person's advocate and say, hey, man, you know, these people still have a lot to give, okay? But memory loss is some of these things that, unfortunately, if memory loss becomes a dementia or a mild cognitive impairment, it can affect a person's independence, and it can affect how they will be treated in the future, okay? And so it's important to discuss, especially as you age, some of the things that patients need to consider doing before things get out of hand, okay? And I'm just going to go through these a little bit at a time. You talk about your power of attorneys documentation, okay? What kind of care does a person want? These are things you don't need to do all at once, but patients need to do this. How many people have had people they care about die or get injured and not leave a will, or not leave, or have had conversations as to what they have wanted, right? These things impact the family members tremendously, all right? So if they can have people who, if you can take the time to at least write something down, it's going to save a lot of grief and a lot of money in the future, okay? So MDPOA documentation, advanced care planning and discussion and documentation. It's happening right now. What do we got going on, guys? A pandemic, right? We have hospital beds that are almost to capacity, and we have even fewer respirators, and we have even fewer people who are trained to run those respirators, right? Somebody who's 75 years old or 80 years old, if they get COVID, okay, what do they want? Do they want, you know, have a conversation with them and say, hey, if you get COVID, do you want to be on a respirator? Okay, yes or no? If you do you want to go 2, 3, 4 days and then say, hey, you know what, I've had my turn, let's turn it over to somebody who has a better chance, right, to make it? These are conversations you want to have, right? Do you want to be an organ donor? Do you not want to be an organ donor? The biggie I've run across a lot in my clinic experience is driving evaluation. Huge independence, especially in the United States. Especially United States, where we don't have a good transportation infrastructure like they do in some European countries, like the good bus system, okay? You don't have a car in the United States, you're pretty much homebound. You lost a lot of your independence, right? But there are a lot of older people who should not be on the roads. My mom, okay? She doesn't wear her hearing aids, she doesn't wear her glasses, okay? She should not be driving. She doesn't, thank goodness, okay? But, you know, we may be those people that the doctor needs to call the DMV and say, hey, you need to bring them in for another driving evaluation class. And do they need to still have a license? Okay. Because our protection as medical assistants is to protect ourselves, the patient, also the greater community. Am I right? Got to protect the greater community. Okay. Education support for like Alzheimer's Association. And a biggie too, care and support for the caregiver. How many people are being cared for by unpaid family members? Right? Unfortunately, it falls on the daughters. Unfortunately, it falls on the women a lot, right? And it's only going to get worse. My first two slides were that Colorado's population is growing, okay? But that the caregiver population is aging, and there are going to be fewer younger caregivers to help out, as well as we live in a fragmented society, okay? Families don't live as close as they used to, right? Nor do sometimes people want to care for other people. Let's be real, all right? So care and support for the caregiver. Usually it falls onto one person. It's usually the woman, and once she gets burnt out, that's it, right? And then going back to the polypharmacy, speak with a clinician about the possibility of minimizing medications, especially those that might contribute to cognitive impairment. All right. And these are all for planning for something if something goes wrong. And again, you know, we have to talk to our patients. It'd be like somebody talking to us as an adult. Okay. What's important to you? Okay. What's most important to you? You know, we cannot be paternalistic. We cannot be maternalistic. We have to make sure our patient is still there as long as they're cognitively intact, to ask what's important to them, what's most important to them. And if my mom's vanity is more important to her than, you know, she hearing and seeing, I have to respect that. Okay. But as soon as she's no longer cognizant, man, I'm gonna put eyeglasses on her, hearing aids on her. All right. But we have to respect our patients. We need to ask them what's important to them. And I hope that's what's kind of coming through with this discussion today. There is a such thing, on a happier note, as a successful aging. There are 5 social ingredients essential to successful aging. And I think medical assistants are part of that. One is purpose, giving people purpose, right? People don't have purpose, they're not gonna make it. I don't care how old you are. Okay. You have babies that were, you know, abandoned, and they fail to thrive because they don't have a purpose. You have 20, 30, 40-year-olds who don't have a purpose. Okay. Same with the older folks. Give them a purpose. Like, hey, why am I taking, you know, why should I take this heart medication? Okay. You can't just say because it's good for you. You need to say, hey, what's important to you? I had a lady come in, she's 70 years old. She smokes 3 packs of cigarettes a day. And she's like, I want to quit smoking. And I said, why do you want to quit smoking? She's like, what? I just want to quit smoking. I was like, no, why do you want to quit smoking? She's like, well, my great granddaughter was digging in my purse and she put a cigarette to her lips, and I want her to be the same way. Right. And I use that. You can use why is that important. So in your care, you could be like, look, this is going to be here so your granddaughter doesn't pick it up on it. This might make you live long enough to see your granddaughter in the Christmas dance. Okay. So if we can customize our care treatments to what our patients want and why they want it, it doesn't just become generic. Does that make sense? Okay. They have a purpose. They want routine interactions that they can count on. They want family and friends. They want to make sure their finances are good, and they want to make sure your planning is right. Okay. Nobody wants to be a burden, right? Whether you're living or when you're dead, you don't want to be a burden. Okay. We can help them with all of these. Social interaction, huge. Leave you a couple more statistics here. There's a difference between men and women. Do you guys agree with that? No, there's no difference. 5-year rate mortality in men with no social ties, meaning that they're the grumpy old men sitting in the lazy boy. No social ties, 160 per 1,000. 5-year mortality. If they have at least 2 social ties, it's a 70 in 1,000. Women do better. No social ties, 70 per 1,000. 2 social ties, 45 per 1,000. Basically, social ties keep you alive. They keep you alive, either by dragging you to the doctor's office or keeping you laughing. Okay. And socially integrated people have lower incidence of cancer recurrence, stroke, upper respiratory infections, and mortality. And this is what we're trying to do with people, is keep them socially integrated, okay, as medical assistants. Kind of leave you with this. Social determinants of health. Our zip code is more powerful than a genetic code when it comes to our health. Living in an area that has more ability to care for you is going to be of greater impact. Enjoy life. There's plenty of time to be dead. That's Hans Christian Andersen. That's kind of dark for Hans Christian Andersen, don't you think? Hey, whatever. And advanced planning, we talked about that in terms of making sure that the patients go and do their paperwork, plan, so that they will have a healthy retirement and rest of their care, okay? I'm gonna scroll through this here real quick. And one last slide before I leave you is the advantage of healthcare planning is that this is a 2012 California report. 70% of patients want to die at home, 30% do. This is the biggie here. 79% of patients want to talk about end-of-life care with their doctors. Only 7% ever report being asked. 82% say it's important to write things down. Only 23% have. So, just going to scroll through this here real quick. Basically, there's still no cure for the common birthday, John Glenn. Couple suggested readings, Be Immortal by Tulga One Day. I love this book, A Guide for the Helping Professions, Physical Change and Aging by Sue Saxon, and Gratitude by Oliver Sacks. And Atul says there's a difference between fighting disease and fighting to help people have better lives all the way to the end. Hope we kind of covered that today a little bit, give you some thought-provoking material to kind of take back to your clinics. I hope it was of some benefit to you, and I want to say thank you for spending the time with me this Saturday morning. Turn over to Dr. Williams.
This was so great. Thank you.
Thank you.
Thank
Thank you, Richard. That was awesome.
Really
Thank
good.
you.
Thank you. Good week.
Thank you, Richard. Was great.
Take care, guys.
Richard, if you could send me your PowerPoint presentation or your notes,
Mhm.
I can distribute that to everybody.
Okay.
Great. Good job. That was really good information.
Thank you.
Perfect. Well, thank you all for coming this morning, and I'll be in touch for the continuing education plan in 2021. And happy holidays, everybody. Stay safe, of course, and hopefully we'll see you in the new year.
Thank you, Carrie.
Yes, thank you, Carrie.
Happy holidays to everyone.
Happy
everybody.
holidays.
Thanks, Carrie. Thanks, Richard.
Thank you, guys.
Yes, thanks both.
Thank you again. Happy holidays. Have a nice day, guys.
Take care.
Thanks, Elena.
Bye.
Hey, Carrie, this is Jen. I just wanted to tell you that I was spamming your email and I called you because I couldn't find the link. So
I see that, and
okay, good. I was like, oh, but then I found it. I just went into my old stuff, so it's totally fine. We're good.
Perfect.
Yay! I'm glad I could be here. And thank you guys again. Have a good one.
Thanks.
Take care. Thank you.
Bye.
Bye. Good job.
Oh, thank you. Thank you for all your help with it. Appreciate it. I hope they can use it. I hope they can use some things.
Gosh.
Richard, that really was awesome. You did a great job.
Oh, thank you. As team member, Dr. Williams helped me out quite a bit with it. So thank her as
I
well.
listened to it the other day. That's my participation.
Good job, Carrie.
Yes.
That's huge, man. You know, have somebody be your soundboard, you know?
She's amazing.
She is.
I think my Listerine story really added.
Oh my God, Carrie.
I'm gonna try some of that.
Let me know
What
how
do
that
you
works out for you.
Do you think
Right.
that would work?
Oh my gosh.
Wonder what the reaction would be.
Ouch.
Right?
Can't even imagine.
Mm-mm. Crazy.
Okay, Carrie, I'm going to text you. I got something to tell you. So I will talk to you soon.
Okay, super.
Okay, bye, honey.
Bye. All right, Richard.
Hey,
Awesome
thanks,
job.
Carrie.
Thank you so
Hey,
much
thanks.
for doing this, because I really do get tired of being the speaker. So
I was going to send you a text this morning about 8 saying, "Oh, I got a stomach ache." That would not. I would know that would be
knocking on your door with some Pepto or something.
Get up, prop you up like Weekend at Bernie's.
Right.
Awesome. Well, that's good. Well, no, hey, listen, is there a time I really want to, can we sit down next week and do our thing for the public health?